inpatient to outpatient psychotherapy. Use it. What you're looking at is data that was Referral Times, but this is a study called, the authors Case and Deaton, two economists who, what they did is they reanalyzed U.S. Census data, divided it by race and age. And as you can see, it's a pretty remarkable finding. The positive spin here is that U.S. mortality rates have been going down for over a century, and that's kind of amazing. And it's going down for all the reasons you expect, right? Low infant mortality, things like antibiotics, better prenatal care, all of the important things that have given the healthy lives that we have today. Except that there's one anomaly on this, and maybe you can see that it's middle-aged Americans, right? If you think of the population of Vermont, it started increasing broadly in the state of Vermont, especially for those folks in that age, and this is true across the United States. And things driving that. If you can, right, they are in drug poisoning, and that's often including overdose and cirrhosis, right, often caused through alcohol use, and suicide. Right? Those are the three primary drivers of that. So what I'm saying is, you know, our community members, these are people we work with, these are the people in our towns, and yet that, you know, they're suffering. And the goal of this program is to relieve a little bit of that suffering. Now, that we're hearing about today, extension of what I'm describing. The mega problem. We're determinants of health that contribute to premature death. Genetic refers to about 30% of it, or about 30% of it. Social circumstance, about 15%. I don't know if you can see that biggest bottom, behavioral patterns. We need to do over time. Right? In some ways, the things that we do daily and over time in our lives determine who we are. Right? Enough, it is who we become. And so to change those patterns of behavior, to health patterns of behavior, tends to increase people's lives, but make people happier. Right? It relieves some of the suffering that comes with things like substance abuse or depression. We also experiences have a direct effect on how people experience their lives later. So one thing I wanted to show here is from a study, the Adverse Childhood Experience Study. This is pretty well known at this point. And what it refers to is adverse childhood experiences are things that we might consider traumas or that might lead to traumatic response in children. Everything from physical and verbal abuse to having a parent in prison, even divorce. And there's them. And people asked how many of them they experienced, and then they looked at how their lives evolved. Things you'll notice is that if people had, adverse childhood experiences, they're the lowest bars, the green bars. Single adverse childhood experience, you see the next one. And once people reach 4 adverse childhood experiences, significant negative impacts on their lives. Right? Includes suicidality, and left there, the smallest, it actually increases by tenfold the likelihood of someone being an injectable drug user. Right? A pretty amount of suffering, right? We see happening, we can predict it, and part of what SBIRT is, they do is these folks when they come into the medical setting. We as a group have brought this into a number of medical settings around the state of Vermont. People often do not seek help for things like depression or alcohol use. They'll seek medical attention. So putting those in the same place makes it likely that we're able to capture those folks. All right, I'm Nebby.
My name is Yambu, and I'm going to talk to you about what the definition of SBIRT and so I'm going to read it with you. SBIRT is a public health approach to prevent, universally screen, and deliver early intervention treatment services for people with substance, mood, and behavioral disorder, and at risk of developing this disorder. So, who are we trying to reach? So, this pyramid was a breakdown of population rate of risky alcohol and drug use. And I see here, 8% of people universally screened display no alcohol or drug risk. 15% display a mild risk. 5% moderate to severe risk for alcohol and drug use. So on the a very moderate, very low risk. The 15% so low and mild use, we do that referral intervention. Last categories, the moderate and severe, then those are the ones we do those are we really do the work. Those are the ones we really did for the SBIRT, as we described it at the beginning of the goals. Those are the ones really we do the effort on, because it's really the prevention. First method. The person screen, we do the initial and the secondary screen of here. And if they screen positive for alcohol, we may give them some additional questions that are part of the standardized tool, which is called audit. So the initial and secondary screen, we determine whether they are at low risk and receive a brief intervention. The brief intervention immediately follows the screenings and use motivational interviewing to explore a person's current substance use and encourages them to set goals to cut down or to just stop altogether. Is that the person scores at a moderate or severe risk. In that case, we focus on a brief intervention on exploring their use and how it impacts lives, with the goal of getting them to commit to substance use treatment. Commit to treatment, we work with them to refer them to services, and we have clinics that we work with where we refer them. The site with clinicians and staff, we offer brief treatment right at the clinic, which consists of up to 12 sessions of cognitive behavioral therapy. The way we proceed is that we give 5. We do vital signs, what we call vital signs, universal triage screening with wellness questions. So those questions are: do you wear a seatbelt? Do you get a flu shot every year? Do you wear a helmet when you bike or when you have? So those are just to kind of break the ice, to get them, open to the conversation. Then we have 3 alcohol questions. We have 4 drug questions about cannabis, prescription drug misuse, illegal drug use, and 2 mood questions with using the PHQ tool. 1 tobacco use question. And
that's the universal screen, those initial sessions that Virginie went through. And then if someone screens positive, go to one of these secondary measures. And so if you're not familiar with those acronyms, because we live in a world of acronyms, the DAS is the drug abuse screening test, the audit is the alcohol use disorders identification test, and the PHQ is the patient health questionnaire, which measures symptoms of depression. The validated screeners that we use, and in the universal screen that Virginie just went over, some questions of those measures are actually in the universal screen. Okay, and so essentially, somebody screen positive on the universal, we know at this point that we're going to be doing a brief intervention of some type with them. And so we ask them the secondary questions, and the secondary screening doesn't take very much time at all, and it can be done statewide. I'm going to talk to you about where this is being done in the state, but in medical settings, it can be done by health educators, medical assistants, triage nurses, social workers, psychologists. Each community where SBIRT is within medical settings has a different type of model based on their clinic flow and their clinic needs. And then within the refugee and immigrant communities, we have our team of cultural brokers, and they'll talk more specifically about what they do, because they're essentially going and doing outreach in the community. There's no medical office where people are coming into. So it's pretty compared to traditional SBIRT model. This process is done within the medical setting in an exam room. Again, for the cultural brokers, it's done on the side of a soccer field, in a car, at a local community center, at the mosque. It just depends on at the homes of the family. It just depends on what that individual's preference is. We're meeting with them. Okay. You see this map of Vermont, and that's basically, we have 18 different sites that SBIRT is in or has been in over the course of the grant, including different types of settings. So members of the Vermont Clinics for the Uninsured, UVM Student Health Center, emergency departments, federally qualified health centers. And that was pretty intentional with the idea of looking at done in different types of settings within Vermont, including the community outreach model that we're going to talk more about here today. So just to share with you a little bit about some of our data from Vermont before we talk specifically about the cultural broker model. And so essentially, we have screened over 71,000 Vermonters. And our goal by the July of next year, and we're confident we'll reach it, we'll have screened over 90,000 Vermonters. And currently, we know that we've provided interventions, including brief interventions, brief treatment, or even referrals to treatment where we're linking them to other services, to over 5,500 individuals. And national research on cost effectiveness of SBIRT has found that for every $1 spent on brief intervention, so that's low risk when they're in the office visit, that cost savings range from $3.80 to $5.60. We extrapolated those numbers based on the number of brief interventions that we have done, and recognizing that this is not a perfect method. There's definitely limitations in the generalizability of it, so we tried to be as conservative as possible. But the estimated costs of those services, cost savings, would range from $547 to $806 per person. In terms of population of Vermonters, you saw the pyramid before where it said 80%, 15, 2.5, and 2.5. This is the actual breakout for the Vermont population that we have screened. And so that's 71,000. 85% fell within normal limits on their alcohol use and their drug use. 11% were in the mild, meaning they only required a brief intervention, and 2% moderate and 2% severe. And then you can see in the pie chart, it gives you the breakout around what are individuals reporting of those that have risky, those that have risky use, 4% roughly alcohol only, 8.4% are drug, and a significant proportion of that is represented marijuana use, and our cutoff for marijuana use was twice weekly or greater. So we're not talking about people who have reported just using marijuana recreationally once or twice in the last year. We're talking about people that are using it pretty regularly. And then alcohol and drug use, so combined. We have a subset of individuals where basically those who receive intervention, so of that pool of 5,500 that we showed you, 10% get recruited into a 6-month follow-up. Our follow-up rate is upwards around 75%. And so it just means that at 6 months, we're able to reach 75% of those people that have consented to us, calling them and saying, how are you doing now? And really re-administering those tools. So audit, and some other questions about past 30-day drug use and other measures. So we found our evaluation, our 6-month evaluation data, that 1 out of every 2 individuals who received an intervention for risky alcohol use were either abstinent, so not reporting any alcohol use in the past 30 days at the time of follow-up, or were within the recommended drinking limits. So they were within what you saw earlier, where it said normal risk at the 6-month follow-up. For drug use, we know that 1 out of every 5 individuals who received an intervention were abstinent from drugs or had significantly reduced their marijuana use 6 months in. These 2 graphs, what this shows you is it highlights the score in the audit, so the mean score population at intake among those in the follow-up sample. So again, that's a subset, 10% of those who've received interventions. The sample size right now is around 600. And the mean score for the audit was 14.9, and that falls in the high part of the low risk range. And we see a significant drop to a score of 9.2, and a score of 8 is within the normal range. So we only see a decrease across the U.S. audit measure over time. And then we looked at prescription use. Everyone, that's a critical issue in our state. What we looked at is what people were reporting for past 30 use around prescription drug use, and how does that change over time among the follow-up sample. There's a very small N. So we had a sample of 53 who were endorsing prescription drug use who were enrolled in the follow-up. And those, we saw a reduction where 53 were reporting prescription drug use at intake, and that dropped to 18 at the 6-month follow-up. So a substantial proportion of people indicated that they were abstinent at the 6-month follow-up. We measure the patient satisfaction. It's important for us to kind of understand, especially within these different settings, how comfortable are people talking about their alcohol and drug use, because medical providers, nurses, et cetera, have indicated to us that it feels a little uncomfortable when somebody comes in for a cold, a stomach ache, whatever the issue is, to be asking them about their alcohol use or their other drug use. And so we wanted to be able to give providers a sense of how is it for that patient, what's their experience of being asked questions and having this conversation. And you can see the bottom 2 ask our anchors, say staff made me feel comfortable talking about alcohol use and drugs, staff respectful, and those are pretty much everybody either agrees or strongly agrees that they felt it was a respectful, comfortable conversation to have. And then, you know, a strong number, at least half or greater, indicate they plan to make changes, they learned more information about how their use may or may not be affecting their health, and the discussion impacted how they think about their use. So along with that, I don't have it here, but and we're going to share some anecdotal stories with cultural brokers, but we do collect qualitative information of people's experience. And one of the things that we are finding that people will say that they really feel the SBIRT interaction is particularly helpful in they feel somebody's listening to them, they don't feel judged, they feel understood. They felt like it made them look at their use in a new way by getting certain factual pieces of information about how they're drinking or their marijuana use or other drug use could be affecting them. So that's been really encouraging. So I'm going to quick turn it over to Artie to just talk a little bit about the training resources, because we are in our last year of the grant, so we're really doing a push to try to offer as much SBIRT training to interested parties as possible. And then from there, we're going to have cultural brokers talk more specifically about their model and what we're doing in the community.
Okay. Yeah, quick. The successes that Jody just pointed out, you know, the way that people feel respected, the way that the people feel accepted in their conversations with the clinicians that they interact with, the successes around the reductions in substance use, those require a set of skills about how we interact with people, ideas about, you know, what people expect when they come into the office and how we talk to them effectively. And so, you know, things we teach is motivational interviewing to all of our clinicians. Teach how to properly screen. How do you screen people in a manner, especially if you're doing it one-on-one in an interview setting, how do you do it in a manner that feels comfortable to people, where they're going to answer the questions as honestly as possible. We teach on special topics, so I go around the state and do trainings on topics that are relevant to whatever settings are needing at any given time. So we're cannabis, that's a big one. Working with youth, so people under 18. And so do longer trainings on short-term substance abuse treatment. So actually that brief treatment model that Virginia was talking about earlier, which is something like you know, below 15 sessions, we train that as well. So if any of you sites are interested, or anyone you know is interested, in organizations in around this, learning special topics or screening behaviors, please reach out. I'll put this up as well, so if anyone wants to get in touch, I'll also be up here if you'd like to reach out. I'm going to pass on to Joe.
So, the cultural broker model, how did this come about? Essentially, my colleague, Dr. Avila, and I were part of a federal grant through the Department of Mental Health to help youth who were at risk for mental and other types of problems transition successfully into adulthood. And one of the things we were coming is that people from different refugee and immigrant communities were not being seen in services. And we know from the literature that there's a significant number of stressors that when refugee and immigrants come into the country, that they've either experienced in their homeland, or not only experienced in homeland, but is compounded, and they come here and have to deal with the stressors of acclimating to a new culture, a new community, all of those different elements. And so they've seen data that indicate members of different refugee and immigrant communities can experience significantly more mental health and substance use, yet we weren't seeing them in services. And so community needs assessment through the Department of Health, where we talked with 96 different members of refugee and immigrant communities, and one of the things we heard loud and clear is that they want somebody from their own community to help provide services. That would help ease their discomfort. It would help them to feel safer, to be able to trust in services. So when we were working with SBIRT, we saw that as an opportunity. So for the last 3 years, ADAP and Spectrum Youth and Family Services, who has really sheltered this program, have supported us to be able to have the cultural broker model. And so we've been growing and learning. And so through April of this last year, which is basically 1.5 years into our efforts, we have screened 1,083 members of different refugee and immigrant communities, primarily the Somali communities and the Congolese Burundi community. But we've been screening the Nepali and Bhutanese communities as well. We had 4% report struggling with alcohol and other drug issues, and of the drug issues, primarily marijuana, and we know that 6% report struggling with depression. Of those people that report struggling with depression or struggling with those issues, 70% have received an intervention from our cultural brokers, with a brief intervention, checking back in with them, or taking them to some type of services. So interesting, when you look at these numbers, the 4 and the 6%, you might think, well, that seems a little low based on what we've been telling you. But you think one of the things that's really important to remember, and these guys will probably speak more to these issues, is that depending on what community and what culture, it can be pretty taboo to even have a conversation around alcohol and drug use. So if within the Somali culture it's against a religion to use alcohol or other drugs, to raise that as a point of conversation can be really difficult. And so part of what has been a huge advantage of this particular model is just to normalize having the conversation. And the other thing too is pieces about surveys. Well, you can talk more about it, but just the whole piece about being surveyed is a whole different experience in itself. And so we anticipate that some of these rates may go up over time as people in the communities start to feel safer about the work that's being done. So is that the door? Okay. I'll turn it over.
Thank you. When I speak on then we always come up with all the list of the challenging problems. Basically, what I would like to say is there are many things that's happening good, and how you all have impacted so well in their life. So I'd really like to appreciate what is happening and all the positive things and all the support that vary from every community, organizations, offices. So without support, we would have been able to, reach this point. So I take a lot of time right now, but there are very, very good things happening in the community. But what we are saying today is there are still some challenges that we take care of. So that's the point that I would like to say. First thing, because we are not bringing the laundry list of things that's always negative. So it may point to that immigrants and refugees bring only problems and challenges. We have contributed significantly to the local community, local economy. In terms of Nepali community, for instance, we have 12 groceries. We have started businesses. We have people who are doing great in their field. So a lot of things happening around. So I would like to make this point very clear that not only everybody, we have come to this country and we have received so much support from every one of you. So we really appreciate it for that first of thing. Now, some of the things are unique to our own community. We come from different parts of the world. And one of our professors said, when you go to a new country, you have to to your own path. Yeah, because it's not set. Like, we can really make a strict guide for the particular community to really excel, proceed. So as we come across, we see some challenges, and so we have to share through those challenges so that we all can be part of that solution. So first, there are some of the things are very common also. Case like openly talking about mental health and substance use is not a thing that it brings bad luck. So not a good thing to start the conversation. What we do when we go to meet them is we start with normal conversation, and eventually in the process we that in such a way that they feel offended, yet we will be able to see them. And our represents it so well that how like we do our own SBIRT. We're remaining within the SBIRT guidelines, but we our own kind of SBIRT. So he puts very beautifully. So you would have said much beautifully than I do. So so when as individuals are told, told repeatedly not to share information about themselves. When they first come, they are overloaded with information. Social security number to anybody. Don't give this, that. Don't talk to strangers. Or don't. There are many don'ts. So we go and try to ask questions, even though we are from the same community. They are not so comfortable. So they're told by the office, and in our where we come from, it is office or the officers, like even if you go in the community from the office, they consider as a very high level person, officer. So officer in that part of all is very strong person. So this I don't see as a peer or somebody's supporting person. So they always have that kind of peer because it was developed in that way, because there is hierarchy and office and normal general population, general public. It's a different culture there. So because of that culture also, anybody who is new to this country will not be comfortable, and even that is for a long time. So difficult for people to really open up. So they're always ready to share the information also. So there is strong suspicion and fear of what will be done with the information. More in the current situation, current administration. There is one in Nepali community. There is one ring on since the new administration came. In the community, people feel that if you, especially those elderly population, if you're in the community event and show up, you like people think that they may be tracked down, their Medicaid and their benefits may be taken away. Strong sense of that, fear and suspicion. They are very scared. So what we cultural brokers we say is not that way, because you have evaluated, you have been screened, you have been there are experts and evaluated by experts and tools, and there are a lot of things that has been done. And I think it should not be tracked down. And if you go to community, it does not mean that you are totally fine. You are good to go and enjoy your life. So that easy to take over the benefits, number one, and you have not done anything fraud or anything like that. So totally fine to go in the community and have a sense of community feeling and share your stories and talk to your peers. It's unknown. From where it came, we don't know, but it's here. So those kind of fears are there. So we as cultural brokers, when we go to meet them, we tell them those things are not true, because it's not like that. And especially in Vermont, we are much safer. Say that. Cultural brokers are making, because money by just screening people. It's so easy to make money, and there is there's suspicion that because back in the refugee camps where they were living, they've been used personal vested interest. So people were scared. So we had that also once bitten twice shy kind of thing. So it is because of that and fear of being they just being we are taking kind of using them as for making business kind of thing. So we challenges also, but we still we are able to do this. We now even think how these guys are doing the work, and I like to proudly say that it's all because of our professors and doctors and our advisors who are so flexible with us. Understand they cooperate with us so much. They every time they have we have 24-hour access to them, and so culturally friendly. They're so flexible. They are so cooperative. They understand us, and they are ready to talk with us anytime when we have any challenge or any problem. So those, and another is we are paid for the time that we screen them. So even us so much backup and support. So that we are able to do these screenings and do this wonderful job in the community. Otherwise, it would not have been possible. So now looking to the specific Nepali community, elements specific to the Nepali community, and depression are the prominent predominant areas of risk. Most, and next is depression, and I think you are very aware that Bhutanese community has the highest suicide rate in national US national suicide rate. And our larger Bhutanese community have because it has become like contagious. So have what the leaders and larger community leaders have done is it is not only publish this information. So it has become like so contagious. So it's just data is sent and it's not out in the media and all that somebody has died by suicide or something. So that's drug use is another particular area, especially in the youth. And older population is struggling to adjust in the new American way of life. It's difficult because where challenges, other language barriers, that those things. And I said before, believe even raising the topic will bring misfortune in the area upon the individual. So, talk about, driving, texting and driving and death. So if you connect that death with texting and driving, it's again misfortune kind of thing. What talk about? So even like when I was medical, I went to Iraqi families to visit home for an Iraqi family, and giving out the poison toolkit, materials around poison prevention and all that. They were to like accept that also. So handing out the flyers about poison prevention is also a taboo. So just imagine how challenging it could be to talk those issues, but we're doing in our own way. So, they quickly say from there about.
So elements specific to the Congolese community. So I'm one of the cultural brokers for the Congolese community, and as my colleagues always say, we don't have a very formal way to get in touch with our clients, to screen our clients. We don't have any office, so we make time and we get in touch with our client through when we're at a party. Say I am at a party and I see my people from my community, and then I introduce the concept of the screening. Depending they react, an appointment, and I follow up with them after that. So that's how we do things. But I can tell you it takes a lot of time, and as Bidou explained, there are a lot of assumption, there is a lot of rumors about, and people are afraid what are we going to do with the information going to collect from us. I mean, it can be really difficult, but when we are able to break that ice, it's then kind of easy to do the work, and that's a really rewarding work, because I mean we are able to bring people to going into services, seeing the social work, or because I mean the other thing is for the mental health issues, it's not an objective sickness. So in our communities, it is really difficult to convince somebody that depression, anxiety are illnesses. So it's very difficult to get them into services, and that's how trust in us can really different. In the Congolese community, I mean, the alcohol is a predominant risk. In our country, it's really hard, and most people drink cold beer. So coming into this country, having a paycheck every week allows them at the end of the week to buy whatever beer they want. So also the depression, the bills to pay, the pressure of being forced to kind of cope with a new culture. All these factors increase also depression, and then push to maybe more consumption of alcohol. So this is how the Congolese community reacts to the mechanism for the Congolese community in drinking a lot of alcohol. In the city, my colleague is not here today, but it's about the same picture, I would say. Alcohol and marijuana are the predominant area of risk for males. Depression are the predominant area of risk for females. Given face, it can be even more challenging to raise the topic of alcohol and/or drug use for fear of being rejected by the community. Yeah, and especially in the Muslim community, there are conversations that you cannot have. One of the reasons also why we have a of culture worker, male and female, it's because also of that, because a Muslim male cannot be interviewed or cannot be screened by a female provider, and vice versa. That's so just to tell you how deep it can be to be able to approach people after these very sensitive questions on the screening. There was also for us the need to build the relationship and trust. The reason why I guess we were trained to be a cultural broker is just most of us here in medical field or our case manager are known in the community for providing services to our own communities, and that for a long time. So we had time, and we had time to build that confidence. We had time to prove that the information is not going to be shared, and how we were kind of that privilege to be a cultural broker for this specific community. Provide on how it will be how it will benefit the individual and their community, and I can re-emphasize confidentiality. Please request for individuals to not be offended and explain why. Be flexible with the approach to just screening so person feel comfortable. So, as we were saying, we have our own way to approach. Can you imagine I go for a screening in my Congolese community? I'm screening for alcohol and I'm offered beer to drink. So you see, it's hard. It's hard. I'm thirsty. You know, so it's those kind of encounter are really the base. I mean, of the relationship we have. I am offered meal. I mean. As I said, it's really the screening is really done in a really informal way, and we really need to make time to connect with the family. Sometimes you are given an appointment at 2, and the person is not even there. The person comes at 3, and the person needs to have time to cook, take care of the kids, and you are there. You make the conversation on any topic. Just take the time for you to be able to connect and to interact with your clients. But the beauty of the work, because not only you screen, but can also help with other issues that impact the treatment of the family. And I'm going to pass it on to Referral, who is also the male Congolese cultural board.
Okay, my name is Symphorien Sikial, and I'm originally from Democratic Republic of Congo. I am a leader in my African community from Congo and surrounding countries. I am a broker for that group of refugees and immigrants. I will share with you what I experienced in screening people from my community. One day, visit a family speaking Swahili, because myself I speak Swahili. This accepted friendly my visit. In the husband, I went to the SBIRT screening process as here early. In my community habits, sometimes the husband entered me by asking all issues not related to the screening. I had the dialogue back to the initial 6 questions. Then it interrupted the conversation and explained to me the situation of and her children on every day since get a job. Tanzania, where the family did have enough resources to buy beer or any alcoholic beverage. When he moved to the US, he got a job and money. Now he can buy everything he wants. He drinks every day after work. He got a small fridge. He eats in the bedroom. He feeds every day with beer, so he can drink anytime he wants, even to sleep. Her to convince the husband to remove freeze from her implored me to convince the husband to remove freeze and all beer out of their home. A discussion answered in the native language. After the exchange, I continued to perform the screening. The husband was positive for risky alcohol use. After a brief intervention, I urged him to describe the pros and the cons of alcohol use. What about drinking alcohol and what he disliked. The risk of heavy alcohol use as the recommended limits for men of his age. I did it with him a plan to quit his alcohol use by advising him steps he can take back his alcohol use, more and more motivated to make change in drinking behavior. I summarize all options in his own words. He may not follow through. And this help from appropriate agencies. He needs to be referred. I home telling them that I'll be back in the coming days. I went to check in and found him concerned the future of his family and the success of his American. Now his goal was to stop drinking alcohol. If from his bedroom, if from his home. I've and in on him regularly. He said that he never drink any more alcohol after a month. Now they enjoy a peaceful life. Benefited SBIRT screening community that the SBIRT screening helps them save money and a lot of information, but important to prevent and reduce disease and be related to alcohol use, problems, genetic health outcome. Thank you.
We just have a little close on 9:30, but I was wondering if we have one more presenter, Rita, just to share another individual story, because I think it's important for you to see the impact that they're having.
So, my name is Rita Newbunny, and caseworker in Association of African Living in Vermont since 2010. So the community knows me very well, and I have a number of stories, like thousands of stories. In like I'm a storybook, so I just wrote it down one story which is very successful through SBIRT program. So I'll read it out to you. And when I go to the people, especially they come to see me in the office, and then I will make appointment with them and visit their house and then listen their stories and do referral things like. So this is a really successful story that I did through SBIRT program. So I want to read it. A man who was in 20s, he called me about his weird behavior at home. So he asked if I could go and see his brother. I went to his apartment and talked to him and asked the person to screen him. He was positive in mental health, risky alcohol use, and drug use. The process of brief intervention, he put his hands in his ear and he said, "I don't want to listen anything, go away." So surprised to hear that, because he knows me very well, but he closed his ear and he said, "I don't want to listen anything, go away, just go away." And then I just gave my card and my flyers to parents and his brother. So went home. Very sick on that night. I unable to sleep also. So after 2 days, he called himself from his brother's cell phone again, and we had a walk. Like I asked him to stay in the parking lot. He came in the parking lot, and then we went outside and talked about food, culture, environment, and then about Vermont cold. All those we talked. And actually, he started to open up, and he that he suicidal thoughts 2 different times when to me that he has two suicidal thoughts, and I asked why that happens. He heard some kind of a strange voice, some bad things like, you are a very bad man, you are a bad person, you are no good. All those voices he heard at night time, and then he did that. So to get rid of all those hearings, he started drinking alcohol and then crack cocaine, all those, and then go to sleep. That's why, to get relief of those, he wants to do that. So I community health center right away and the walking appointment, and I went with him personally to talk to his primary care physician, and then there also he scored positive in depression and in drug and alcohol use. So I said to the primary care physician, I'm also trained screener, I can screen, and I did, and he scored positive. That's why I bring him here. And then he referred to Howard Center and then to connecting culture behavior therapies. And then they did treatment there also. They give some kind of medication. So I want to take medication there. He said, I don't want to take medication. I'm all right. I'm just hearing voice. That's it. So could like weekly visit all those there on the treatment. And then he called me. I'm not satisfied with all the medication I providers help. And then I said, do you want to see a priest? That's what I said to him. And then he said, he ignores that. It's very personal. And that night he attempts suicidal attempt. So her is so scared. And then he called me again. So I bring him to the he trust on me. So there is a trust building, and then good relationship as a I see they see me as a sister. So I priest, and then priest process in the priest also. So they did 5 mornings healing exercise to a very young man. He's like 20s in the after 5 years he stopped coming in the priest, and then he gave me, and I asked he wants a job. That's what he said. I was like so surprised. After 5 days he come and asked, he's looking for a job, and we have a job employer in our office. He put him in a job, and now he is doing 40 hours job per week, and completely healed from that, from the mental health illness and then drug. He stopped drinking, he quit drugs, and he is now he got a driver license. He is driving. He bought a car, and he is like well in the community right now. After 2 months, he said, "Thank you, yeah, you saved my life." Yeah.
For allowing us to go a little over. I think you can see the intensity of the work and the amount of support these individuals provide in our community. And I have to tell you that you see there are 4 here. We have 6, and they are all part-time, so all are 8 hours a week. So we're less than 1.5 FTEs, and they're reaching out to all the communities in addition into the other work that they're doing in their full-time jobs. And I think we just highlight that the work they're doing is incredibly important, that it is an incredibly flexible approach that we're learning as we go, that we support each other, and that, as Vidur said earlier, we know communities are struggling with their own traumas and their own substance use and mental health. There are also a lot of good things. And so our effort is to try to help intervene as early or as much as possible. And the flexibility of our approach allows us not only to do the screening, but to continue to follow and be a resource to them over time and really make sure they get the supports they need, whatever those supports might look like for the individual, recognizing that we need to have that cultural sensitivity, that it's not one size fits all. With that, I just want to thank everybody for their time, and thank you for your patience in allowing us to go a little over. Oh, sure.
This is just outside of our work right now, but you was talking about the phrase was really from the same, we call it Vermont example. It is not advertising, and it looks like advertising, but we are doing really in September 6th, started both annually. It's the 5th year that we have been doing this. All voluntarily, we have all our extra reports, and we from ourselves from the event. So we have in the same department, we take 1 or 2, and then we have some invitations to join this. Let's take 1 or 2 do join us and complain, and we have all necessary information there. Thank you.
And it's ryan.lane@vermont.gov.
No, we're just going to log you off, if that's okay.
Totally fine.
Yeah, I just logged you off. I have to switch users. It's in a different place on this laptop than things a different place on this keyboard than mine. So I'm always typing like this whole thing.